Okay. I think we can get started. Um, and so I will introduce Dr. Winblad to everyone. This is Annalisa Winblad. So she did both her medical school and her radiology training at KU. Then she went over to WashU for her breast radiology fellowship, which one of my good friends from medical school just graduated from there, and she's just like raved about it. And then she's an associate professor with the Department of Radiology. She is the division director of the breast imaging and co-director of the clinical operations for the breast program at the University of Kansas. And so I have sent her multiple questions after Courtney Rudy kind of put me onto your trail. So I'm sorry, that's Courtney's fault, not me. But we are so happy to have you. This really spurred from ACP just a few months ago. They came out with all their recommendations, and it just created this like huge stir, and everyone talked about it for so long, and we were just like, we just need to get someone in here to talk about kind of the nooks and crannies and all of these different areas that probably primary care doctors should be associated with. So it's so nice to have you.
Yeah, thanks for having me. And actually, thank you for sending along all of those questions. They were fantastic. And I think common areas that people have confusion, both patients and providers. So I think there will be some great talking points. And I know you did not want any slides, so I don't have them, but I do have lots of prepared slides I can send afterwards to your team that have lots of information that probably answer some of those questions, or at least will direct you to the right contact or give you the right verbiage that you can talk with your patients about. So I can also send you some things afterwards too, if that's
Yeah.
helpful.
Like the more information, the better. The more I learn about it's like every topic. It's like the more I learn about it, the more like nuanced and difficult it becomes. And so, yeah.
Yep.
Okay, so like everyone knows, this is a case-based presentation, and we'll kind of pose questions, and we'll have conversation. Dr. Comfort is not here today, so it's just me. So if there's anyone else that wants to pop on with a question, I will monitor the chat. And if anyone really, if I don't see the chat because I'm by myself, just pop in and ask the question or raise your hand. So we'll start off with Maria. So she's a 42-year-old woman coming to see you for the first time. And she doesn't have any personal or family history of breast cancer. She has no known genetic mutations. She has no prior chest radiation. She has never had a mammogram either. She just comes to her visit and she asks, she says, my friend says that I'm already late on getting my mammogram. Should I have started screening at 40 years old? And I think this is the most basic question we can have, like when the heck do we actually start screening women? And there's a million different recommendations. So how do you take all these different recommendations and boil it down to something that's clinically useful?
Yeah, it's a really great question. And, I think historically we used to have far more variable recommendations, quite honestly, than even more recently. So almost all societies and institutions recommend women of average risk start screening at age 40. And that even includes the United States Preventive Services Task Force, which used to actually be kind of, I think, the biggest source of confusion for patients and providers. And so we recommend at KU as well, start screening at age 40. We are, as you all know, probably as well, that we're starting to see even an increasing incidence of breast cancer in women younger than 50. A third of breast cancers and minority populations occur before the age of 50. So we see a lot of breast cancer women in their 40s and even more and more in their 30s now. And certainly we highly advocate for average risk women to start at age 40.
Okay. I'm gonna like actually like I think pop forward and ask another question that's not exactly in line, but I mean then the question is like who do we need to screen before 40? What questions should we be asking? Are there certain like risk assessment models that you use that are particularly helpful so that we catch these people who are higher risk before 40?
It's also a great question, and I think will line up with one of your questions you have later. And a really thoughtful point that we'll talk about maybe later too is that now most societies, including ASBRS and SBI and ACR, all recommend that we start doing a formal risk assessment for women starting at age 25. Um, and that's to identify patients who are at higher risk than the average risk population. I also think that's really confusing because there are all sorts of different ways that we can risk assess patients and what does it mean to formally assess them. So I would say in the primary care setting, our goal is to identify patients, at a younger age, before the age of 40. Wonderful if we can start at 25, to identify the most important things like strong family history, history of chest radiation, genetic mutations present in a family member, those sorts of things. Now, there are lots of models available. The most common models that we use um, in our breast imaging clinics and the high risk prevention clinics are going to be the Tyrer-Cuzick model, and also the Gale model. One nice thing about, there's like the Gale model, there's a breast cancer prevention tool or risk assessment tool online that you can easily use. Um, to plug in the numbers, what's the patient's age? Do they have a family history? Have they had a prior biopsy that demonstrated atypia? Do they have a known genetic mutation or those sorts of things? So you can put all of those, answers into a risk assessment tool if you choose to use a formal risk assessment tool. And we consider patients who are high risk as someone that has a lifetime risk of 20% or greater. What's interesting is we're starting to see NCCN and some other groups look at short-term risk prediction as well. And I think that's beyond the scope of what we'll talk about here. I think the most um, important thing for all of us to be aware of is that 20% or greater lifetime risk equates to high risk of breast cancer. And I don't necessarily expect everyone to use a tool either. I also think you can use recognizing important high risk factors and then recommending that patient be seen in like breast cancer prevention clinic or seeking an appointment with a genetic counselor to determine if genetic testing is necessary. We're really fortunate at KU that our breast cancer prevention clinic team sees patients who have high risk. And I even talked with Lauren Nye, who leads that group. She's a medical oncologist who is one of the leaders in the breast cancer prevention clinic, along with Dr. Carol Fabian. They're fantastic. And if you notice that you have a patient who has a strong family history of cancer, the most important risk factor being a first degree relative with premenopausal breast cancer, a patient who has a known genetic mutation, or a first degree relative with a known genetic mutation, if you have a patient that had a history of chest radiation for a different cancer treatment at a young age, or a patient with a history of a breast biopsy that was atypical, those patients can be sent to the breast cancer prevention clinic at KU where they can, meet with a provider who can talk about, do they need high risk screening starting before age 40? Do they qualify for a clinical trial or chemo prevention or other risk reducing strategies? Even things such as weight loss or medications can be used for risk reduction strategies. So we have a lot of great resources for patients who are high risk, and we're fortunate to have all of those resources at KU. We also have a genetic counseling service. They're phenomenal. So that's another avenue that you can send patients who may have some strong family risk factors that you recognize. And when you start talking about family history, you can send them to genetic counseling and they'll do an even more in-depth formal risk assessment where they'll actually, look at their, family tree and really outline all of their true risk factors and decide if genetic testing is necessary or if high risk breast cancer prevention clinic would be a good route for them. They'll even give guidance on screening. So we have a lot of great resources. The most important thing is identifying patients who are high risk. We're certainly seeing a lot of patients who do need to start screening earlier or need additional types of screening to supplement mammography.
Do those two models the Gale model I'm familiar with. What was the other model?
Tyrer-Cuzick model. It's actually phenomenal. And really, the most important thing is that you're using a model that takes family history into account because that's a really, important part of a model. And, the model we use in our breast imaging clinics when patients come to us for a mammogram, a screening mammogram, a diagnostic mammogram, any type of mammogram study, we have them fill out a little intake form and we put information in and calculate that as well. It does rely on patients actually putting that information in. A lot of people don't, or maybe don't do it correctly, but it also gives us an idea of risk assessment. And we try to capture those patients too and put a little verbiage or statement in their report that may say, you have reported, some risk factors that may make you have a higher lifetime risk of cancer. And then we give information about our breast cancer prevention clinic and those sorts of things too. So we will also try to capture those, but we also may not see those patients until they start screening.
That's what I was thinking is like
Mhm.
it's still our job from 25 to 40. I mean, it's
Yeah.
like, okay, great. Do those models typically give you the same percent about like of lifetime risk? I mean, is there a huge difference between those two that we should know?
Not always huge. Our
Okay.
providers are, for the most part, using the TC risk score, the Tyrer-Cuzick risk
Yeah.
model. But certainly both models are going to ask about some of the most important major risk factors. And, if you're not using a model, just recognizing those really important risk factors that would make most women at higher risk for breast cancer is certainly enough to send them to the nurse navigation at KU and get a breast cancer prevention clinic appointment.
Okay. Okay. Um, Switching gears to the conversation between annual and every other year mammography. So, I mean, we do annual mammography. That's what comes up on our health maintenance tab. We try to be as good as we can about that. I think we have like 50% success rate. I mean, it's not wonderful. But so what's the argument for the 2 year versus the 1 year, and where does that stand with all these major organizations?
You're so right. There are lots of arguments. I'll answer one question really quick just because I saw in the chat.
Yeah.
You're right. You will see differences in TC and Gill score. Also, some TC scores will add breast density into their calculation. I will tell you in our breast imaging clinic, we do use breast density in our calculation. You're also not going to know breast density until a patient's had a mammogram. So that'll also be tricky. And yeah, your younger patients, you will not have the breast density knowledge yet. But you're absolutely right. Breast density can change that quite a bit. So, but back to the annual versus um, every 2 years argument. So lots of great arguments. We recommend that patients have a screening mam every year for about three kind of major reasons. So first and foremost, the mortality reduction. We know that patients who are screened every year, the likelihood of dying from breast cancer is far, far less if they're screening every year. I think the mortality reduction is, if you're screening every year is 47% versus 28% or so if you're screening every other year. So there's a big, life savings there, of course, and that's incredibly important. Um, we're also seeing an increased incidence of breast cancer in our younger patients. Those are also patients who tend to have higher grade breast cancer. So those are actually also going to be cancers that are more likely to grow quickly or advance faster than would some of these lower grade or more indolent sort of breast cancers. So when we're screening every 2 years, the cancers, unfortunately, that we're missing are the higher grade cancers, right? Because those are actually going to change a lot or potentially pop up in that year time. And those are quite honestly, from my standpoint, the cancers I want to find more than any other types of cancers. Those are typically the cancers that are going to kill a patient or cause serious morbidity. They're going to be the types of cancers that need more chemo or larger surgeries that grow faster, that really cause life altering, effects on a patient or a patient's family. And those are also the cancers we more commonly see in our minority populations or younger populations. So every other year makes us more likely to miss pretty high grade cancers, and that's a big deal. Um, but another really important factor in screening every year versus every other year is morbidity. And, all the screening arguments love to talk about mortality, and that truly is the most important, I believe. But we sometimes overlook the difference in morbidity for patients. And we're in an era now where breast cancer treatment is very personalized. There's a big push and promotion to kind of de-escalate treatment with chemo and radiation and surgeries. And so our goal is actually to, decrease morbidity of breast cancer treatment for patients. And we know that when we find cancers when they're small and have not spread, that those patients are more likely to need less or no chemo. They're more likely to have smaller surgeries that don't have bad outcomes, less lymph nodes removed, and less long-term outcomes from that, maybe no radiation. So lots of benefits for patients who have small cancers that have not grown to a large size or have not spread. So the morbidity difference is huge. And we actually just did a research project at KU So those are all long-term morbidity things I just described. We just did a research study at KU for our patients looking at the short-term morbidity reduction for patients who are screening every year. And it was really cool. It was really incredible. So, not only do patients need less chemo, they have smaller surgeries, those things, but we looked at all of our patients and tried to see like what difference does screening make in that pre-surgical breast cancer planning period. How are patients who are screened every year, do they need fewer breast biopsies, fewer
Mm.
lymph node biopsies, less contrast imaging? So all of those factors that take time and money and increase the time and um, time morbidity of breast cancer treatment, the cost of breast cancer treatment, lots of factors that really affect women early on. And it's pretty incredible the reduction in lymph node biopsies, breast biopsies, contrast imaging, faster time to treatment, multiple factors for patients who have screening every year. So there are lots of benefits beyond just reducing death from breast cancer for patients who are screened every year. So my recommendation and the recommendation at KU and from all of the societies that treat, patients with breast cancer is starting at age 40 for average risk and then screening every year. And, fortunately, that's a covered service with no cost sharing for patients with insurance right now. So that's really great too. And certainly that's our recommendation.
Okay. And I would assume like the every other year argument would just be increased biopsy without actually having breast cancer, anxiety, time committed, overall expense to the health system with annual screening is their point versus
Yes.
finding breast cancer earlier and treating earlier and having better morbidity.
Yes, and it completely depends on how you look at the results of, if you're looking at, oh, the cost is decreased here, well, it may be actually a lot more expensive to treat
Mhm.
that, so
Yeah.
there are so many different ways you can twist the data. And, ultimately it's a patient and patient's decision, but there's a lot of cost savings in other ways. And, you know, it probably depends on where you get your mammograms and where you get your imaging. I would say, a place like KU, patients aren't getting, we have very low recall rates, low biopsy rates, things like that. So, most patients don't, some patients definitely have, stress and anxiety from having a mammogram, but most patients don't. Most patients would want to know and find a cancer when it's small and treatable versus the anxiety and stress from a later stage or larger cancer that requires a much different, treatment course.
Okay. When we're putting in the mammogram for patients and it's, with the screening mammogram, there's 2D and 3D, and I don't know the intricacies of it at all. I just put in screening mammogram. Can you talk through those things? Because sometimes you'll see things come from outside imaging centers and we'll have it labeled out. I'm like, I don't know how that compares to ours. And
Yes, it's a great question. And the great thing at KU, we only offer 3D on all of our studies, so patients don't have to worry about that. It is certainly now, I would consider it standard of care, modern technology that I would expect for all of my patients. You are going to have facilities in surrounding areas that you simply just can't afford, newer equipment or updated technology. So you're still going to see 2D mammography used at some facilities. Absolutely. At KU, they're all 3D technology. And the difference with that, so with 3D technology, it's identical experience for a patient. It's just a single image. The difference is that the image that we obtain is kind of reconstructed so that we can scroll through a patient's breast a little kind of in a similar way to how you would scroll through a CT scan. It's different but similar. And the great thing about 3D over the last 10 to 15 years, we continue to see data shows us that we find more cancers and that we recall fewer things that are normal. So the goal of, breast cancer screening is to maximize our cancer detection rate while minimizing our recall rate. And we know that 3D mammography certainly helps us do that. So we use that for all exams. So our patients here are fortunate.
is there anything better on the horizon?
For mammography, I would
Mhm.
say no, not right
Yeah.
now, but there are always advances in our technology and types of, I mean, always advances with things like especially in the contrast imaging world. I mean, now we offer contrast enhanced mammography at KU, so lots of different things coming down the road. Um, I think we'll see a future, hopefully not too far away, once we have more data on our contrast enhanced mammography, where our patients who are using that study as their supplemental high risk screening may not need to do 3D mammography screening in addition to their CEM. So I think we'll just see more personalized approaches to screening and how we screen patients with, especially our high risk or dense breast population over the next several years. I don't foresee any drastic changes in the technology itself, though.
Cool. All right. So Maria gets her mammogram done. It's BI-RADS 1. The report says that she has heterogeneously dense breast tissue, category C. All right, this is what happens when Dr. Comfort's not here. She gets a letter in the mail about the breast density per the new FDA mandate and calls her PCP in a panic, asking about what that means for next steps. So can we walk through, I guess, the four types of breast density and how exactly it should alter our path moving forward?
Yeah. So you're correct. There are four different types of breast density. The breast density is something the radiologist sees on a mammogram. So it truly looks at the amount of, I would call it fatty tissue in the breast versus fibroglandular tissue, which is made up of all those little TDLUs and fibroglandular elements in the breast. And there are two non-dense categories and two dense categories. The two non-dense categories are fatty and scattered fibroglandular densities. And this is very specific verbiage used by the FDA and kind of mandated by the FDA. So you'll see this no matter if your patient has a mammogram at KU or elsewhere, the verbiage in their lay letter and then the report that you see should be very similar. In fact, it should be identical. And then the two dense categories are heterogeneously dense and extremely dense. So patients who have heterogeneously dense or extremely dense tissue are termed dense, and they will have that verbiage in their lay letter they receive for their mammogram screening report, as well as the report that you see. And it will have very specific verbiage that says you have dense tissue. This is a normal finding. It's nothing to be alarmed by, but this puts you at increased risk for cancer. And it's also more difficult to find cancer on mammogram. So talk with your doctor about, I think the FDA language is your individual situation, which always is, so funny to me. So at KU, because patients are notified of dense tissue, we do offer supplemental screening for patients with dense tissue. And quite honestly, most programs or practices around in the region or even around the country sometimes don't offer many options simply because I think they know it's confusing for patients to figure out what to do. It's in many ways inefficient for us to offer some of these studies because of the confusion, but we know at KU that every patient has different needs and preferences, different access to different types of studies, and they have different types of insurance that may cover different types of studies. So we have, over the last 10 plus years, really expanded our supplemental screening services, and we offer all of the services that are endorsed by the medical societies for supplemental screening. So we offer breast MRI. Abbreviated breast MRI is our recommendation for dense breast screening. We offer contrast enhanced mammogram. So that is a study that uses a mammogram machine, a little bit different technology, but it uses a mammogram machine. It actually uses kind of similar concepts as how we use breast MRI. So a patient does have IV contrast for a CEM or contrast enhanced mammogram study. And then we offer ultrasound, and we offer automated breast ultrasound at our Westwood and Olathe campuses. We offer handheld ultrasound at all campuses. So the society recommendations for supplemental screening are that breast MRI is the best. It's the most sensitive. But we know not all patients can have breast MRI, right? So there might be patients who may be claustrophobic, or they may have size constraints. They may have an indwelling pacemaker or other things that make it more challenging. They may, have other issues. So if a patient can't have breast MRI for any reason, contrast enhanced mammogram would be my next recommendation, then followed by ultrasound. And really, those are based on the order of sensitivity for breast cancer detection. So breast MRI finds the most, CEM finds the next most cancers, and CEM is really approaching breast MRI for the cancer detection rate and also the specificity. And then handheld ultrasound or automated breast ultrasound are wonderful tests. They don't have as high of a sensitivity as breast MRI or CEM, but they are still good tests depending on where you have them performed. So I will say I think ultrasound screening is the most variable across the country in performance. We at KU have subspecialty breast imagers and breast sonographers doing these sorts of studies and are very good. And we have really good cancer detection rates and those sorts of things. But it certainly is probably the most variable across the country in regards to, positive predictive values and cancer detection and recall rates, that sort of thing. Let me make sure I missed. What are the So that's a great question. We'll talk about the coverage for those. So, and I will say for ultrasound screening, I would say probably the one benefit is if you have a patient that's just like, I don't want an IV, I don't want contrast, that's a great option for them. And then we absolutely want to take the cost into consideration, access into consideration. If sometimes patients just have a very like, I only want to go to this location, or I only have this day available to get a study done. So we absolutely take patients, needs into consideration. And if they have a supplemental test, I think that's phenomenal. Some patients don't. We have a pretty high utilization rate for supplemental screening at KU comparative to the country, which is really cool. And we have pretty high cancer detection rates at KU because of that. So when it comes to cost, I think this is so interesting. So one thing to note, and you may be aware that the Find It Early Act was reintroduced in end of 2024, I believe. So there is right now a push for national coverage, not just for screening as we see this, but for all diagnostic imaging or supplemental screening tests. Some states do have laws requiring coverage, but even some of those laws in some states or communities don't necessarily mean that it might be covered, but there still might be cost sharing associated with that. Patients have such variable plans, different deductibles, different types of copays and cost sharing, and we know that's very confusing. It's interesting, even in the last several years, I think most of us would consider that breast MRI has historically always been the most expensive. It's interesting the last year, I mean, I think mine was $20, for screening this year from Blue Cross Blue Shield. So I feel like it is so variable. And we used to kind of always talk about breast MRI, might be the most expensive and ultrasound is the cheapest. Honestly, depending on someone's insurance, that's not always the case. I will say one thing is great about KU, the MyChart cost estimator has improved a lot. It's not perfect, but it's certainly getting a lot better and does take into account patients' individual plans and, whether they've met deductibles, that sort of thing. So I don't want to lie to you and tell you that breast MRI would be the most expensive for a patient if in fact it may not be. I will tell you my CEM one year was more expensive than my breast MRI one year. So I think it does vary, and patients can absolutely call their insurance company or look in their or their MyChart cost estimator tool to see what their cost sharing may be. They're usually pretty good predictors. Um, but in general, even though Kansas does not have laws for coverage of supplemental screening, I don't see these, you know, um, we see all these studies approved by insurance payers. We're not struggling to get these approved, but certainly patients may have very different cost sharing.
Yes, because it was interesting because you're right. I think like 3 months ago, I talked to Dr. Polsak and I was, talking about breast MRI and I hate that we can't order anymore. And she was like, actually, they're a lot cheaper than they used to be. And she was, like she had encouraged me to try ordering them basically to see if I can get them covered for patients. And I found a lot more patients be able to get them done at like reasonable cost. Because a lot of people will say like, well, maybe it's like an every other year you'll get an MRI to supplement if it's $200 or something like that. And it's like, I mean, it's all that things that PCP are good at, like, where we talk to our patients and we try to like find their values and like maybe that's where it fits. But um, is there Is there any head-to-head data between MRI and CEM and ultrasound on morbidity associated between those three?
Yeah, so it can be really challenging to look at mortality and morbidity because you need such long-term data sometimes
Mhm.
for some of these. However, interval cancer rates really are help us understand mortality and morbidity pretty well. And MRI has fewer interval cancers than any imaging study. So we can infer that the mortality morbidity benefits from a breast MRI are, the best right now. I will tell you though, CEM is really proving itself to be pretty close. The cancer detection rate for CEM is approaching that of MRI, and actually some studies show that CEM might be more specific, so fewer false positives. One area historically, and this depends on where you have your images done too, like some of this is where, if you're having your breast MRI read by someone who doesn't read a lot of breast MRI or who has poor equipment and things like that, your outcomes from some of that may be very different. But our data is really good for both. But across the country, CEM is really approaching MRI. So it's a fantastic study for patients. And a lot of patients feel very, oh, I'm familiar with mammogram. It's convenient. And, breast MRI is pretty convenient at KU too because we offer at several locations. But across the country, that's not the case. So CEM is very convenient for a lot of people, familiar for a lot of people, that sort of thing. So it's a great study. Ultrasound, like I said, it's a great study at KU. I would probably hesitate to go other places and have um, ultrasound screening because I don't always think the benefits of ultrasound screening are the same. Ultrasound is going to tend to find masses. So, and that's important. Masses tend to be invasive cancers. So our goal of supplemental screening is to find small invasive cancers that have not spread. That's the whole goal, is to find those interval cancers we would miss. Breast MRI is certainly going to find the most probably at this point right now.
Okay. And it's an abbreviated breast MRI. So what do we tell patients
Yes.
about how long it's going to take?
So this is also fantastic, and a lot of data. We actually, gosh, we started offering abbreviated or limited MRI as I believe the order is. Gosh, maybe I want to say at least 7 years ago, probably or more. So we were kind of at the forefront of abbreviated MRI. And what we've learned about the sensitivity of MRI is that for in the screening world, when someone has a normal mammogram, they're asymptomatic, shortening the MRI to include just a few very specific sequences and taking out a lot of the stuff that helps us maybe more when someone has a cancer or things like that. And shortening it so it's a really short study allows more patients to have the study. And not just because it's a shorter amount of time and we can fit more patients in to the very limited time slots you have. MRI is a very expensive machine. We don't have access as challenging as we all know. So we were able to increase our access for breast MRI tremendously. But what was also really great is a lot of patients weren't doing breast MRI screening because it just took too much time, or they were a little claustrophobic and it was just, oh, I can't sit in there for 30 or 40 minutes or something. I mean, an abbreviated breast MRI is less than 10 minutes. I mean, you're not in there very long. It's a very short study. Same for CEM. It's a very short study. CEM and breast MRI screening are going to be shorter than a handheld ultrasound screening, so they're, or ABUS screening. So they're short. I mean, they do require IVs and contrast, and those may be deterrents for patients, but they're really short studies. And so most patients tolerate them pretty well.
Yeah. But it's like, I mean, CEM, I would assume, uses the exact same mammography techniques with the compression. And so, like, if women are like, I just can't stand that, then MRI or ultrasound. And
Yes.
yeah.
It was interesting when we first offered CEM, we began offering CEM only for patients who, couldn't tolerate breast MRI, like when we first began CEM several years ago. And, we really learned how many patients were not getting the either supplemental screening. We first were offering it for new cancer patients who couldn't have a breast MRI because those were critical that we offered them a stronger, more sensitive evaluation for their extent of disease to make sure they got the right surgery and right treatment first. And what we found after we began offering is all these patients who actually needed MRI screening that just couldn't get MRI for one reason or another, maybe a contraindication or access or inability or claustrophobia, whatever. I mean, now we do CEM. I would say 90% of our CEM studies are for patient screening, and we have not seen our breast MRI volume decrease. We've simply seen more patients now have access, which is pretty cool and incredible. So,
Yeah. Okay. Um,
Do
let's
you
see.
mind if I
So
ask one question?
yeah,
yeah.
Taylor.
You talked about access. So do patients have to wait longer for these supplemental MRIs or contrast enhanced mammograms, or what's like more accessible? And then to follow that up, does it really matter? Should they be doing every 6 months, or should they do them both at the same time? Or is there a recommendation for that?
That's great. So when it comes to supplemental screening timing, what I tell patients, we have some high risk patients, for instance, who have their screening mammogram at one point of the year, and then they, have their supplemental MRI or, every 6 months. And, the theory behind that is, okay, you're potentially capturing someone who's more likely to have a higher grade cancer at intervals in which you would hopefully, if they did have a really high grade, triple negative or grade 3 cancer, that you would have more opportunities to catch that at different intervals. And so there's certainly an argument to be made for saying having them spacing them out, 6 months is a good strategy. What I will tell you is I think the best strategy is a strategy that works for the patient. If a patient is like, I'm only going to do this if I can come in once and get it done, awesome. I would, because there are different studies. I mean, the reality is, a breast MRI looks at a patient's breast tissue completely different way than a mammogram. So it's from my perspective, it's not going to matter to me when they have that done. But we certainly have a large group of patients that their preference is because maybe they just, hey, I take off this day of work every year to get some of these appointments done, and that works for me, and that's how I'm going to get it done. Awesome. I think that's great. So really, whatever works best for the patient, there's probably a small argument to be made for every 6 months. And then you had one more question. Now I'm forgetting it. Oh, with access. So I will say I think our access at KU is pretty fantastic. We actually recently started offering breast MRI at the 47th and State Line location, which actually expanded some of our breast MRI access even more. So your patients can call, and I mean, like today, there was there was an open abbreviated breast MRI slot today, but CEM the same, we have pretty good access to. These are not exams where you would call and it's 6 months to get in. They may call and say we have one in a few days or next week or something like that, but the access is pretty good.
Yeah, I wonder if that's just like they have like an hour-long scan and then like a 30-minute scan and there's a 15-minute that they can't do anything else in. You know what I mean? It's just like these like little places that you can't get normal MRIs, and I wonder if that's a place where they can put those. And so, okay, so Dr. Carlson asked something on here. I don't know when this would fit in down the road, but she has, and I had to look this up. She's had patients with findings of PASH on their screening, which I guess PASH is pseudoangiomatous stromal hyperplasia. You know that. I do not know that.
Very impressed.
So how does that affect things?
So not at all. So we used to
Yeah.
get a lot more excited about PASH, I think, in the past, than we do now. And certainly it depends on the pathologist and how, what's in the report. But PASH is not considered an atypia. So that does not affect our screening. The types of pathology atypias that we really care about nowadays are ADH or atypical ductal hyperplasia, atypical lobular hyperplasia, lobular carcinoma in situ. Those tend to be kind of the big players in regards to atypias. If a patient has their imaging at KU and their biopsies at KU, and we have their pathology and identify an atypia, all of those patients will be discussed in our multidisciplinary conference with our not just radiologist, but the breast pathologist, the breast surgical oncologist, the medical oncology high risk team. So we have an entire group of people who will be making recommendations for those patients with atypias about what to do next. So hopefully, for your patients at least that come to KU, that process should be pretty easy for our providers, hopefully.
Cool. And then just another comment. We have Dr. Sabgati looked it up, and so he says A bus without insurance 508, fast MRI 1900, CEM 1100. $100. And so those are just, those are not the numbers hopefully that patients are looking at, but that is just what it looks
No,
like without
yeah, I
insurance.
agree. Those are not the number. And breast MRI is interesting too because our limited gets, cut in half on the back end and it's all very confusing. But hopefully your patients aren't seeing that cost. I think we had the financial team do an audit, I don't know, several months ago as we were looking at this, and most patients were not paying even close to those numbers. So, but some of it I think is, patients have to know a little bit about their insurance coverage and, what sort of plan they chose, and definitely speak with the financial counselors, look at your MyChart cost estimator, or call your insurance payer for more information if necessary. We don't want patients to have any surprises either. Yes,
And
the limited LMTD that you've posted, that is the correct abbreviated or limited exam. Thanks, McLean.
Do you know
yeah,
if it gets changed on the back end? Because I'm pretty sure I have not ordered that one yet, and I've ordered a lot of these.
Oh, then you're ordering it correctly because I see your name on a lot of things. So I'll look at it, but I'm pretty sure that's at the correct order. And we could have people flexing it when they actually schedule it, flexing it to the correct order because that's the breast MRI orders are something we would reflex. Like if someone, for instance, accidentally orders a unilateral MRI or something, we're going to reflex that to the correct order. So that could be happening, but I'll double check the
Yeah.
order and let you know.
I haven't had anybody screaming about the bill, but the one I had done, I think, was the order that I've been putting in. It seemed way longer than 10 minutes. I thought it was like 30 to 40, but I
So
didn't have to pay
that would
that.
be a regular. That would be a
And
regular then.
I maybe paid 150 or 200 towards my deductible, which is similar to like an A bus payment. So,
Yeah. And that was probably the full then.
okay. All right.
You
Good
went
stuff.
with the Cadillac version.
Limited. Okay,
very-
limited.
only the best for you, Nicolene. This is great.
I just really wanted to experience the full thing so I can explain to my patients how they, Superman the massage table.
And I'll send that out, Dr. Polstack. That's a really great, just to the rest of our group so that we're all ordering the right thing. It's great when people can get the right thing, but if you tell them 10 minutes and it's 30 or 40 minutes, and they're like, I can make it without Klonopin for 10 minutes. You're like, okay, how about 40? Yeah. So, okay, awesome. Okay, so there are a couple of other just like instances where I feel like I had some knowledge deficits where like there's special circumstances, like there's like women with silicone breast implants or just like these other kind of nuanced things and like ordering handheld versus regular ultrasound on the back. So can you like, are there things that pop into mind for you on like some nuances that we should know about for screening for general population, but maybe certain populations within there?
Yeah, great. So patients with implants, you don't have to order anything differently. If a patient has implants, we will, the same screening orders apply, and we do recommend screening for patients with implants. And the only difference that we do in regards to screening for patients with implants is that we do implant displaced views, meaning they'll take an image of the breast tissue with the implant kind of displaced posterior so that we get good compression of the tissue, and then us not lighter but lighter compression of the full implant to include all tissue. So the exam will be maybe a few minutes longer. We do recommend screening, absolutely. For patients who have implants and dense breast tissue and decide they want ultrasound screening, we recommend handheld ultrasound instead of automated breast ultrasound. Some patients with implants, we can do a pretty good job of, an ABUS probe is a really large probe that you put over a patient's breast, and it, scans the whole breast, but you've got to have really good compression and coverage with, the tissue to probe needs to be aligned well so that you get a good quality image. For patients with implants, sometimes that's challenging. So we will reflex patients who, let's say they come in and had an order for an ABUS screening ultrasound after their mammogram. We will flip that to handheld ultrasound, and then we have a little verbiage statement that we'll put in saying, yada yada, your patient was originally scheduled for this. This was reflexed to handheld because they're whatever tissue, yada yada. That way, that's why we did that, because we want to make sure that if a patient is coming and taking time to get a supplemental screening study, that we get a really good study for that patient. And we know that there are different reasons why we may need to do different types of studies. And for patients with implants, that's one of them that we will reflex those to a handheld ultrasound to make sure they get a good study because that can be more challenging.
Yeah.
And patients, okay, great question about
Yeah.
the patients with bilateral mastectomy. So patients who have had bilateral mastectomies, that should mean that they have had all of their breast tissue removed. So for patients with no breast tissue, we do not need any sort of annual screening. So, the one caveat to that is I will say sometimes we have patients who have had mastectomies and locations, maybe not by a breast surgical oncologist, and maybe they have a lot of residual tissue. If you ever have concern that a patient, says they have a mastectomy, but you're doing a breast exam or something, and you're like, they seem like they have a lot of breast tissue, don't hesitate to send them for screening. We'd be more than happy to screen that patient. But in general, patients with bilateral mastectomies should not need screening. In fact, that should hopefully be, there aren't a lot of benefits of needing a mastectomy ever, but hopefully that is one of them. Something to also keep in mind for our patients who have gender affirming surgeries, that doesn't always mean they've had a mastectomy. So a top surgery may still have a lot of residual tissue left behind for cosmesis. And we certainly want to make sure that patients who have breast tissue should be screened no different than other patients. So something just to kind of think about is, hey, if this patient has residual breast tissue and they meet age or risk criteria for screening, don't forget to screen that patient. But our bilateral mastectomies do not need screening. So great question.
So is this something that you can, like if you ever have a question about it, like if you don't know if they got all of the tissue, the patient doesn't know, I feel like that's very common where it's like you're just as hopeless kind of as them. And are you able to send them for mammogram and have you weigh in on whether or not there's still breast tissue
Yeah,
present?
totally. I mean, if there's ever concern, we'll just do it. I mean, and there are some patients, and I'm sure you have some of them, that even if they've had a mastectomy, they're like, I'm getting a screening mammogram. I want it. It
Mhm.
makes me feel better. So we will not deny patients who just really feel that's important. Or there are some patients are worried that they have residual tissue left behind, or some providers that are worried. So we will not turn people away, but our recommendation is that it's not necessary. And we know that most patients, and if so, that includes flap reconstruction. So if you have a patient that has, flap reconstruction surgery, those patients have had their, breast tissue removed as well. They don't need mammogram screening. So flap reconstructions, mastectomies with implant reconstructions, completion mastectomies with no reconstruction, those patients can no longer need to be screened.
Okay. I feel like I'm doing this question a lot of injustice for being the last like 8 minutes. But can we talk about stop times for mammography when we can start counseling patient on you probably don't need it anymore, how that discussion changes from patient to patient?
I'm actually really glad you brought this up because I think this is, to me, I think more confusing for people than when to start and how often to screen, quite honestly. And it's something we don't really talk about enough. Because I have patients who are 78 and they are probably going to live to be 98 and they should absolutely continue screening. So most of the medical societies recommend that patients continue screening as long as they are healthy and you expect them to live, more than 5 to 7 years. I would recommend continued screening. And, you know, actually, we have a lot of patients in their 70s and 80s with small little cancers removed. They may not have chemotherapy or radiation or anything like that, but there is still a big benefit to when something is small and they're going to live a long time. You would like for them not to have a locally aggressive breast cancer be the cause of a very difficult end of life,
Mhm.
part of their medical care. That those are really challenging. And so we have a lot of older patients that we've diagnosed breast cancer on, and they do really well, and they're probably going to live a long time. I think even harder are the patients who are 60 and their life expectancy is less than 5 years and they're still getting screening. Those, quite honestly, are also, I think, really tough discussions. I'm sure that you and your colleagues all have to have, because I think those are actually the more challenging, are patients who really don't need to have screening when they're still young, but maybe that doesn't need to be part of their care plan. So I really think it depends on the patient's health status and life expectancy, and whether or not they would be treated for a cancer if they were to be diagnosed. It's hard for us in radiology when we see a patient or just see their image. I don't have the clinical context for that patient. If I know, we actually have a little statement that we'll put in some patient's report, but I have to know that, like, for instance, if it's sometimes I'll have like an 89-year-old come in for screening and it took 2 technologists and they're in a wheelchair and all, all these sorts of things. Those are patients we'll probably put a little statement just saying discussion about continued screening might be beneficial, that sort of thing. And we try to be sensitive about that. We don't want to imply that someone has a poor life expectancy or something when we know we're not their clinical provider, but those are important discussions. And I really think it should be based on their life expectancy, their current health status, and whether or not they would be treated for breast cancer. And treatment, at an older age doesn't always have to include chemo and radiation. So if they could still have a lumpectomy and they're going to live a long, healthy life, I would continue to screen them.
Cool. Yeah, I mean, for us, like primary care providers, we just live in the healthcare maintenance tab. Does anyone know how long mammogram stays on for? I don't know. Is it 80, 75? Thank you, Bree.
I
Appreciate
wouldn't be
you.
surprised if it's 75, just
Yeah,
based on kind of, I think, most of the data that's out there. And there's a lot of really good new data coming out on, patients older than 75 and their benefits from screening. And it really is dependent on life expectancy and health, because there are lots of benefits. When we looked at our data for the research I was talking about with morbidity, we had a very large number of patients above 75 and also a large number of patients before 40. So I was pretty shocked at our KU population that we're doing biopsies on. We have a pretty large young and old population who are, getting treated and doing really well. So it's interesting.
yeah. I mean, 75 is not. I mean, it's old, but it's not old. Like, you know what I mean? It's one of those where we see people who are 75 all the time and they are just doing amazing. And
Yes,
there's, yeah, like you said, that there's just that difference. Sounds like
I know. I see 85-year-olds like that at KU that I do biopsies on. And I'm like, they look better than some of the 60-year-olds, so I get it. Yep.
right.
I can ask that question more clearly, probably. I was just, since I've newly have been ordering MRIs now for the past year or two, just haven't felt real comfortable continuing that annually as a supplemental screen in very dense breasts, but it sounds like that could be okay as long as it's covered and they tolerate it. Is
Oh,
that right?
totally.
I
Yeah.
mean,
I mean, it's still going to be the more sensitive study.
right.
There's a lot of new data coming out too on patients who are older than 50 and extremely dense breast tissue, just that being like even instance in NCCN guidelines about those patients might even start in the future qualifying for things like chemo prevention and other things. So certainly we have a lot of patients that do abbreviated breast MRI every year as their choice exam. And, some people love it. They don't mind getting an IV. It's cost effective screening for them. They scheduled a year in advance, so it's not an access issue, those sorts of things. So I think it just patient preference, their insurance coverage, that sort of thing. Maybe in the next year or two, we'll see even more changes if the Find It Early Act is, passes, that sort of stuff. And so maybe there will be changes too for coverage in the future for all patients. Who knows?
And does Westwood or Olathe prioritize those images if they are ordered at the same time, like they did with ABUS, being somewhat back to back?
So, what's interesting is, yeah, I mean, some of it just depends on when the patient wants to come, needs to come, time of those sorts of things. We do that for ABUS or handheld ultrasound predominantly because ultrasound is really only a good screening tool when it's in conjunction with mammography.
Mm.
And, you know, ultrasound is and the performance of ultrasound is variable, and there are a lot of, you're hearing people be like, oh, the her scan and just ultrasound, and I don't want mammogram, I'll just do ultrasound is a pretty poor study to do as an isolated tool for screening. It's actually really poor and not recommended. So it does help in settings to do it after the mammogram, so that if you need to correlate findings on an ultrasound, you can also have that mammogram with it. And then on top of that, it helps because patients' breast density may change over time. So sometimes it's nice to have the mammogram first, because if you have a patient that now is kind of lived in that middle and now they've entered into, a scattered density and they're not dense, we will do the job of saying, hey, you're no longer dense. We can cancel this and hopefully save them some money or time. So we do try to capture those. I think because of the way those are scheduled, we tend to probably more easily be able to do an AVAS or handheld ultrasound right after screening mammogram, but we can typically kind of fit screening mammograms in everywhere. So for most of our patients that have a supplemental study on the same day, if we can, we try to do their mammogram first, even just to make sure you're still dense, that sort of thing.
Thank you.
Yeah, perfect. Awesome. That was, I mean, great. Just great information. We're going to I think we're going to synthesize this information and just send it out to everyone. And this is one that I'm just going to send to everyone I know because it was just so remarkably helpful.
Oh,
This stuff
thank
confuses
you.
me so much. So we're very
Confusing. It's
appreciative.
confusing. And
Um,
I can send you some slides later too, if that would be helpful with
yeah,
information about orders and information. So I can also send you some stuff and you can decide if it's worthy to send out to your colleagues. So,
yeah, that sounds awesome.
okay.
Dr. Witt says you are a rock star.
Oh, thanks, Dr. Witt.
We love. So, well, we appreciate your time. Thank you so
Yeah,
much. We'll
anytime.
reach out with any questions, but thanks everyone for coming and showing up.
Okay, thanks everyone.
Appreciate it.
Have a
Bye.
good day.